Alrighty, so this is a little bit of an announcement is that this is going to be our final cardiology echo clinic for the year. Dr. Toft is going to be leaving us to go have a baby, so it's very exciting. Congratulations, Dr. Toft. So yeah, this will be our final one for the year. Just stay tuned. You should all be receiving the listserv reminders about when the clinics are happening. So we will let you know whenever we're ready to get going again sometime in 2021. So with that, I will open it up to see if anybody has a case that they want to discuss with Dr. Toft today. If you do, please feel free to unmute yourselves.
Yeah, Dr. Toft, just wanted to run something by you that I saw this morning. A gentleman, he's about to be 77. He's got diastolic heart failure and permanent AFib. He actually sees Dr. Baker, and he's doing well from that standpoint. For his AFib, he's on Xarelto for his anticoagulation. And he's got this rash on his legs that when I was looking into it, it's like pretty petechial. It doesn't bug him. It's not puretic. It's not really spreading up beyond his knees. But it looks like maybe a Xarelto-associated rash from what I was looking at. Have you seen a lot of that?
Yeah, great question. I honestly have not seen it a lot in clinical practice, even though that's, I like Xarelto, but I prescribe more apixaban, Eliquis than I do Xarelto personally. So this certainly is described and people can get rashes with Xarelto, but I had one patient say they had it, but this was the type of person who gets lots of reactions to things. So I think it's reasonable to switch agents or try a period off of the Xarelto and see, because it certainly is described in the literature. I just haven't happened to see a lot of it.
Okay, yeah, and he's got a pretty extensive med list. He's also got Parkinson's and is on several medicines. Oh. So the options are many, but just when I was kind of scrolling through some pictures, it looked like Xarelto was the prime suspect as far as what I saw on Google. So.
And I would be in the same boat with you because, like I said, I like the apixaban a little better, but I go with whatever their insurance covers. So yeah, let us know. Let us know if that ends up being the case.
Do my best. Thank you.
Yeah, thanks, Dr. Warko, for sharing that. Any other cases or questions for Dr. Toft today? Oh, a question here from Patty. Why do you prefer Eliquis?
I mean, this is one of those nuanced things that cardiologists would get all in a tizzy about, the tiniest little data things, so take it with a grain of salt, I'll admit. Any novel or direct oral anticoagulant is superior to warfarin in terms of efficacy and amount of time spent therapeutic. So I go with what insurance will cover. But if I have a choice, the reason I like apixaban is because I think that the bleeding data is slightly better than the data for Xarelto or rivaroxaban. But keep in mind, there's not been a trial comparing them head to head. So this is just looking at the data of apixaban versus warfarin, and then the separate data of rivaroxaban, Xarelto versus warfarin. The downside of the apixaban or Eliquis is that it's twice a day, so compliance can be an issue. So I take all that into consideration. And honestly, like I said, it really ends up being whatever's affordable.
Good question, Patty. Thank you. Any other cases or questions from the group right now?
I have a question to throw out to everyone just in terms of what you all have been seeing. In a lot of our cardiology groups, so we've been discussing some of the changes in patterns that we're seeing because of COVID. I think probably in Nevada, we're in a little bit different boat than a lot of the sort of major metropolitan areas. But there's been a lot of delays in people seeking care for MI or for decompensated heart failure. Are you guys encountering any of that in your practices? Have you noticed any difference in kind of the flavor of cardiac cases that you're seeing, or does it feel business as usual?
I know that earlier on, kind of in that end of March, April, beginning of May, definitely had a lot of people slow down across the board as far as follow up on their chronic stuff, whether that was cardiac or diabetes or It sort of feels like we've kind of gotten back to business as usual. Although, looking through the data, maybe this is just a underreporting thing, but the actual decrease in heart attacks or, some of that stuff is pretty interesting to see, like, why is that the case? And again, it could just be a reporting issue. But it looks, at least from some of the stuff that I looked at, like there was actually a decline in some of that stuff, which is odd.
Yeah, I think time will tell if we sort of get some retrospective data suggesting that there have been more cardiac illnesses. The two things that the data seems to be saying, we've seen an increase in cardiac arrests, no doubt about it, in the major metropolitan areas that have been hit hard. So that's terrifying, of course. That's my area of research interest, so I pay attention to that data. But then the other thing that they've just been quantifying, they're doing some post-COVID MRI studies and suggesting that a huge percentage of COVID patients have some kind of myocardial dysfunction or inflammation, even if they're asymptomatic after COVID. So we're seeing cardiac arrests happen in diagnosed COVID patients, but outside of that 14-day window. And so they're feeling fine, and then all of a sudden cardiac arrest. So it'll be interesting to see if we end up with something like COVID cardiomyopathy, if that becomes a thing, later down the road. But yeah, it's all in flux. It's all changing. But I feel a little isolated personally from a lot of that data because we're not in, this major metropolitan center. All right, thanks for that input. All right, any other questions or comments? If not, speaking of unusual cardiomyopathies, that's what we're going to talk about today. Troy, are you going to share the slides or me?
You can pull them up from your end. Yeah.
Okay, great.
Better.
Yep, I like that. I like control. Okay. All right, well then we'll just go ahead and dive right in. Just a reminder, I don't have the disclosure slide here, but we are recording today. So if you wish to not be part of that recording, please let the Project ECHO team know about that. And I think everyone here is familiar with our format, so we're just going to dive right in. So to kind of wrap up our heart failure series that we've been doing over the past many months, I thought we would end with looking at some of the less usual causes of the heart failure syndrome. We've spent a lot of time talking about both systolic and diastolic dysfunction, both inpatient and outpatient, but now I wanted to dive into a few of the other less common but important entities that you may encounter, and then talk specifically about what may differ when it comes to diagnosis and treatment of these diseases. So I'm going to start with a case from long ago in my training. So this was a 42-year-old woman with Loeys-Dietz syndrome, which is a connective tissue disorder similar to Marfan's, for those of you who are unfamiliar. So she had already at this young age had an aortic aneurysm with a repair, which is common in these connective tissue patients, and then also had migraine disorder. So she presented with an acute severe migraine, nausea, vomiting, the whole works, but then developed progressive substernal chest pain and shortness of breath over the course of hours, which was not typical for her migraine symptom cluster. So she eventually sought medical care and was quite sick when she presented. Her blood pressure was 80/60, pulse was 110. She had crackles bilaterally a third of the way up the lung fields. She had an S3 gallop and an elevated JVP. And so as you would imagine, EKGs, troponins, etc. Her first troponin was 8.9, which is a respectable troponin. When I get called for 0.08, I'm not excited. 8.9, you have my attention, yeah? But then the second one was down to 1.7, so an interesting pattern. This is her first EKG when she shows up. And I think the notable thing on here, hopefully you can see on your screen, she's sinus tachycardia. So again, you have my attention. But the most pronounced thing here, we don't have true ST elevations or depressions, but we do have a pretty pronounced QT prolongation. And if you look in lead 2, that's probably where it's most pronounced. You see that the T wave barely ends before the P wave begins. That's a subtle finding, and when you're looking for ischemia, which was kind of the top of everyone's list here, that might be something that escapes your notice, but it becomes relevant to her case later on. You might be tempted to look at an AVL and think, is there a 0.5 millimeter ST elevation here? That would be very subtle and wouldn't meet criteria for immediate cath lab activation, but you wouldn't call this a normal looking EKG by any stretch. So that combined with the troponins, we're gonna definitely pay attention and do some more diagnostic workup. What's interesting is what happens to our EKG 48 hours into the stay. Other things have happened as well, but I wanted to show you the progression back to back. Does anyone have any comments about what seems very abnormal on this EKG? You can say it out loud or type it into the chat. No takers. Everyone feels like they're back in med school again.
No, there's some significant ischemia on interlaterales.
Okay, and which exact finding is making you call it ischemia?
It's a deep T-wave inversions.
Okay,
Symmetrical.
good. Yeah, so there's these T waves are very remarkable. I totally agree. And they're from not so much V1, but V2 all the way through V6. So that's a huge territory. But it can also convince you that inferiorly, there's also some symmetric deep T-wave inversions. So now we're talking about 2 to 3 different artery territories with these deep symmetric T-waves. And I want you to keep this pattern in mind because ischemia is certainly on your differential. There's a few other things that cause this pattern. If you see these really deep, profound T-wave inversions like you see in V5 and V6, if you see those in V1 and V2 in particular, that has the name of Wellens T-waves, and that signifies impending LAD doom. That usually means a critical left anterior descending stenosis. But here V1's not so much involved, so I'm not thinking that there's so much Wellens T-waves. You also can see this pattern of T-wave inversion aside from ischemia in the setting of neurologic abnormalities. So intracranial hemorrhage would be the classic case where you see this. Seizures also sometimes can cause this pattern. And then there's one other important entity, which is what we're going to discuss, which also does this. And then I would also remark that the QT is still prolonged. The end of the T wave, again, is butting up right into the P wave. So this buzzword of deep symmetric T wave inversions throughout plus QT prolongation has a particular diagnostic. It makes me think down a particular pathway, which I'll show you. Next steps, let's pretend that in the first 48 hours of her stay, nothing else was done. What kind of diagnostics, therapeutics would you all be interested in at this time?
Echo, CT angiography.
Great, so echo for sure. And then some kind of evaluation of the coronary arteries is definitely in line. And I would argue with that abnormal of an EKG plus a troponin, I would want her to go to a cath or invasive angiography. Did you say CT angiography meaning like for PE, or were you thinking of the coronaries?
Well, depending what's available.
Sure.
Yeah, but I would also I would consider the angiography of the pulmonary vasculature and the coronaries as well.
Okay, great. And you know, she came in with this migraine, but it's kind of atypical. I would probably scan her head before I'm giving her all kinds of anticoagulants and antiplatelets, even though she didn't have focal neurodeficits and my suspicion of an intracranial hemorrhage is low. You know, it's easy to scan someone's head in the hospital, and the consequences of missing a bleed would be, you know, pretty devastating. So I'll show you kind of the main deal of what is done. So she does get an echo. Woo-wee! EF is 10%. And here is your buzzword, apical akinesis. That should ring some bells in your mind of a specific diagnosis. When we say apical akinesis on an echo, we usually are pointing towards this one diagnosis. And then her angiogram, maybe surprising, maybe not surprising to you, she just had luminal irregularities. That just means little lumps and bumps, but no significant stenoses. So she's not had an MI to cause any of this stuff. So what has she had? Well, through the course of the stay, she had serial echoes and her EF improved to 35 to 40%, but she developed an LV thrombus. Remember that apical akinesis? It's a perfect setup to get an LV thrombus. But she was put on therapies for her low ejection fraction, beta blocker, ACE inhibitor, and then therapeutic anticoagulation, which in this day and age, we would have started before the LV thrombus formed. I don't remember in her case if it was started before or after we found that LV thrombus. So here's where the story gets very interesting. Literally on the front lawn of the hospital, waiting for her ride to come pick her up, she gets a transient episode of aphasia. Wah, wah, wah. So that suggests that she had an embolic phenomena from that LV thrombus, and she had a little piece of it flick off and give her some aphasia. But then it ended up resolving, thankfully. She comes into clinic, a repeat echo, EF 60 to 65%. The apical thrombus goes away, and no further embolic phenomena. So we're going to talk about what her final diagnosis is. And Dr. Bayun on the money says Takotsubo. Dun, 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 ding, ding, ding. That's correct. So let's talk a little bit about what Takotsubo is. I like to use the term stress cardiomyopathy, and I'll tell you why. So this is a Takotsubo. Hopefully you've all have heard that terminology before. This was first described in the Japanese literature, which is why it kind of has that name, Takotsubo. This is a Japanese octopus pot. So it's a trap for octopi where they swim in to the narrow neck, like a bullet, and then their legs get all and caught up and they can't get back out of the octopus pot. And the reason that this disease has that name is because the original descriptions of the pattern of how the LV looks just like this Takotsubo. So here, this is a picture in systole, an LV gram. You have a catheter down in the LV, squirting in contrast dye to highlight it. The base of the heart is squeezing. See, the walls have come in. But this entire apex, mid to distal, anterior, inferior, everything wall, has not moved at all. It's ballooned. So when you hear apical ballooning or apical akinesis, that is suggesting this particular version of stress cardiomyopathy. And see, it looks exactly like a Takotsubo. So what is it? Well, here's kind of the seminal paper in the English literature that described stress cardiomyopathy. You'll notice this is the Valentine's Day week edition of New England Journal of Medicine. And so you'll also may have heard this called broken heart syndrome. So fun side note, this is written by one of my mentors from training, Lon Wittstein. And all of these people are people I train with. So, I feel proud. Like somehow I'm responsible for this New England Journal article. I am not. But Lon was telling me one time that after this was published, his wife, he claims, was watching Grey's Anatomy in the other room. Again, he claims it was his wife and not him. And he hears these words, and it's a direct quote from this article of his that they're describing stress or cardiomyopathy or broken heart syndrome using his words. So that's pretty fun. So, from New England Journal to Grey's Anatomy, you can decide which has a bigger readership. So this is kind of the original mainstream description of this in the English literature. So what exactly are we talking about? What are kind of the diagnostic criteria? I will tell you that this is a clinical diagnosis, and so there is not consensus, but I just take whatever Lon tells me because he's kind of the world expert on it, and that's what I go with. And once you start looking for this, you find it everywhere. So this presents for all the world like an MI or acute decompensated heart failure, chest pain, shortness of breath, edema, all of that. So you're thinking something cardiac, but you're thinking MI or some kind of decompensated systolic heart failure. There is usually some kind of sudden stressor. That's why we call it stress cardiomyopathy. Emotional, physical. I have seen everything from surprise birthday party, meeting your biologic parent for the first time, asthma attack, migraine headache, as we just discussed. I've even seen, which is kind of unfair, an MI cause stress cardiomyopathy. So that gets tricky to make the diagnosis. Sometimes they're totally unaware of what this is, or it's just, oh yeah, I always yell at my husband, and this time it gave me heart dysfunction. So we try to go backwards and identify it, but it's not always the case. My favorite one of all time was this woman was getting a facelift, and when they're doing the facelift, they inject sub-Q epi a lot of places to control the bleeding. And we'll get to, when we talk about pathophysiology, there's definitely the idea that catecholamines have something to do with the etiology of this. So our hypothesis was that injecting all this sub-Q epi somehow got systemic and gave her stress cardiomyopathy, but she crashed and burned during her facelift. So they rolled her into our cardiac intensive care unit with all these drains coming out of her face, intubated, for us to take care of her. We were like, we don't do face drains here. So that was interesting. She did great. She recovered. So the troponin is mildly elevated, but it's elevated a lot less than you would expect for the degree of LV dysfunction. So if you remember this case, her EF was 10%, but her troponin was only around 8 or 9. Usually to have an MI big enough to knock down that much myocardial function, you're looking at greater than your upper limit of normal. So usually it's the 5 to 10 range is what we see, but it can be lower, it can be higher, but it's usually mild in comparison to the degree of LV dysfunction. And then there are these classic changes on the EKG. ST elevation is possible. So these will look like STEMIs and get taken straight to the cath lab from time to time. And then they shoot the coronaries, nothing, shoot the LV gram, oh, it's stress cardiomyopathy. And then as I was pointing out on the two from this patient, QT prolongation, very common. And then these deep symmetric T-wave inversions. They usually happen about 48 hours after the event. And what's really cool is, if you get serial EKGs, they often resolve by the time they leave the hospital. So it's these really dramatic looking EKGs, and then they're totally fine by the time they leave. And then importantly, the pattern of LV dysfunction, the walls that don't move, are not in a coronary distribution. And there's really 3 recognized or described patterns. So apical ballooning is the one we looked at. That's the one that's truly called Takotsubo. But you can also have 2 other patterns. Mid-ventricular ballooning, where the base and the apex squeeze, but the middle does not. It looks like a top, you know, like one of those old-fashioned spinny tops. Or basal ballooning, where the apex squeezes down, but the base is dilated. So it kind of looks like a spade at the apex with this big base. That one is very rare. I've only seen it a couple of times. And then there should be no coronary disease that explains this, but that emphasizes the fact that everybody gets a cath because you have EKG changes, troponin elevation. So a diagnostic angiogram is really part of your workup. And then the LV dysfunction must improve. And it usually improves over the course of months. Even within 1 month, I'll often see that their LV function is improving or back to normal. If the LV function isn't back to normal or their baseline by 6 months out, then I'm questioning the diagnosis and there might be something else going on. So these are actually the same ones I already showed you from this woman, just better quality to demonstrate that deep symmetric T-wave inversion. And again, she does have a little bit of ST elevation going on in some of these leads. And then here's some different patterns. So we already looked at the apical ballooning, but here's another show of it. This is in diastole, so everything is relaxed. And then here's in systole, and you'll notice the apex hasn't squeezed at all. The base has squeezed, but the apex is almost in the same space as what it was before. And then here is an example of that basal ballooning variant, which is again, very rare. So here again, in diastole, we just have the normal looking heart shape. And then in systole, when it's squeezing, look, the apex is gone because it has totally squeezed together. There's no dye getting in, the walls are touching, but the base hasn't really moved that much. So those are 2 of the variants that we can see. And you'll often get an echo report where if we suspect this, we'll say, suspect Takotsubo or pattern consistent with stress cardiomyopathy, something along those lines. Oh, I didn't mean to show you this, but these are just more pictures, both a cath picture and an MRI picture. This MRI, we used to have some different hypotheses about the pathophysiology, seeing this enhancement on MRI, suggesting some kind of edema, but we haven't really been able to figure out what that's all about. So here is an example of this woman, in fact, this is her echo. So if I can orient everybody, this big chamber is the left ventricle, left atrium below it. On the right of your screen, right, or left of your screen rather, is her right ventricle and right atrium. So if you look at the LV, you'll see that the base, which is closest to the mitral valve here, those walls are thickening and moving towards the center. But then once you get into that mid to distal range, nothing is moving. The walls aren't thickening. They aren't moving towards the center. They're just getting pulled along with the base that's moving. So this is a very profound, and it's a huge territory. This is the anterolateral wall. This is the inferoseptal wall. These are two different coronary arteries that feed these distributions, and it's just a standstill. You can imagine why this is a perfect setup to get a clot right up here, yeah? Because the blood is just pooling. And sometimes we'll even see what we call smoke, which is we'll actually just see bubbles kind of moving around inside the ventricle, suggesting incredibly sluggish blood flow. And then here is what happened, as I just mentioned. This is a beautiful apical thrombus in her LV. So if you notice, the LV has started to pick up now. So these walls are starting to move a little bit better than what they were in the last picture. They're still not normal, but they're better than what they were. But right up here in the apex, ooh, that is a juicy thrombus. It's bouncing around with systole. You can see the embolic potential, right? This is the kind of thing that gives me a little bit of palpitations. And then subsequently, here is when her LV function has recovered almost to normal. So again, note the difference in the walls. You still have a little residual thrombus, and it is really bouncing around down here. But the apex is moving again. And see, this is why the stroke potential is so high for these patients, because the apex that wasn't moving, you know it's going to get better. And that's different than an apex that never moves, where the blood can just kind of lay down in this laminar thrombus. This is a dynamic process. And when that apex starts moving, that's going to make your embolic potential higher. So this is actually a higher risk embolic situation than someone with chronic apical akinesis, chronic cardiomyopathy. So this is some data looking at how their LV function changes over time in a series of patients. And you can see again, by 2 to 4 weeks, by 1 month out, the average EF has recovered to normal. So you really do expect a rapid turnaround. And sometimes even within their hospital stay, the EF starts to improve as it did for our patient. Okay, so what causes this? Because this is pretty cool, right? Nobody knows. There's ideas. Maybe direct myocyte toxicity. Again, there has been a lot of data collected that you have elevated catecholamines in this. So maybe that does something about calcium overload, free radicals, blah, blah, blah. All the normal things that people say that cause stuff is what we say for this. But we've never been able to definitively look at that. There's a lot of interest in maybe microvascular spasm. So the little vessels that are diving down through the myocardium, maybe those are spasming and causing this dysfunction. But the interesting anatomical distribution is truly not understood. There was excitement at one point thinking this is about beta receptor density, because if you remember back from training at some point, there's a different density of beta receptors in the apex than there are in other parts of the heart. But it turns out it's the opposite of what you would expect for catecholamine toxicity. And that wouldn't explain your two other patterns of anatomy that you see. So that really hasn't panned out. The other thing that we do see epidemiologically is that more females are prone to get this than men. So we don't really know what that's about. And then there's a much higher proportion of a previous psychiatric diagnosis, in particular depression and anxiety. So there's a lot of things going on, neurohormonal, brain-heart connection. Those of you who spend time in the hospital and never get consulted from the neuro ICU, we see a ton of cardiac dysfunction in the neuro ICU after strokes, hemorrhages, seizures, etc. And so we think that there's probably a similar etiology here, but we've really not been able to categorize or understand it. It kind of doesn't matter, because the good thing is these guys get better, but it would be nice to understand it. So how do we manage these people? It's pretty similar to managing heart failure with a few exceptions. So they can be the full range of the spectrum. They can present with no symptoms. You just get an echo for whatever other reason, or mild symptoms, and suddenly you have this apical ballooning and you're like, oh, you go to talk to them and they say, oh yeah, my daughter crashed my car last week, or some other stressful event. Or they can be in cardiogenic shock on mechanical circulatory support in the ICU. So you manage those presentations per routine. But the difference here is that this is my personal practice pattern, which comes from Lon Wittstein, so it's a good practice pattern. We don't have this written in guidelines because we have no randomized controlled trials of this, but this is a good idea, so you should do it too. If there's truly apical akinesis, meaning it's not moving, and we'll say that on the echo report, they need to be anticoagulated. For me, I'm a purist. When I'm anticoagulating to prevent an LV thrombus, it's heparin and Coumadin. I don't use the direct oral anticoagulants for this purpose, simply because we have no data in that realm. Would I say that you're wrong if you use Xarelto or one of the others for this? No, probably not wrong, just data-free zone. But I'm in a data-free zone by doing this as well. So lots of way to skin this cat. But you should anticoagulate them for sure. And I do that until the apex is recovered. And so until I see that the apex is moving again. Apical hypokinesis, just meaning less movement, I do not anticoagulate those people because I think that the risk probably outweighs the benefit. It's truly when the apex isn't moving. And then we had a discussion a couple weeks ago about standard systolic heart failure therapy, and that's what we put these people on. And we put it on for a while. As I showed you, the EF usually recovers in about a month. I usually give them heart failure therapy for at least 6 months. There is some data that they have a higher risk of recurrence of stress cardiomyopathy once they've had one episode. So I usually leave them on for about 3 to 6 months, and then we discuss, you know, if their blood pressure hasn't really tolerated, I've had to peel back, then I might consider stopping. But in general, I think of ACE inhibitors and beta blockers as vitamins for the heart. And so they're just kind of good to prevent this from happening in the future. So again, there's a lot of nuance to that, but you should keep them on and for some time after the EF recovers. And I always do the repeat echo at 1 month and then again at about 3 to 6 months. Okay, so that is Takotsubo, stress cardiomyopathy, stress-induced cardiomyopathy, broken heart syndrome, all of the above. Before I go on to other causes of the heart failure syndrome, any questions about that case or this disease entity?
Just a question on the anticoagulation. With that higher incidence or recurrence, as far as the anticoagulation goes, is there any thought to just putting people on more longer term anticoagulation if you're worried about a recurrence?
Yeah, good question. My pattern has been to stop the anticoagulation once the apex recovers, just because your risk from being on long-term anticoagulation, you have a higher bleeding risk. And for me, the risk of ACE inhibitors, beta blockers is a lot lower. So that's why I'm willing to continue those longer. So usually either until the apex recovers or the LV thrombus resolves. That is different than someone with chronically low EF. So let's say you have someone with an EF of 15%, they had an LV thrombus 2 years ago, they got put on Coumadin. I personally never stop that Coumadin because that apex is never coming back. This one is a different situation. So for me, I stop that Coumadin once the apex has recovered. And the risk of recurrence is elevated compared to the general population, but still low overall. So great question. I know there was one in the chat.
Sorry, real quick.
Go ahead. Yeah.
And that's only for the apical variety, the more common variety, right? So if someone were to have one of the basilar or that kind of middle section, you would not necessarily need to anticoagulate them in that situation?
Yeah, that's right. It's really the apex that has the highest risk of a thrombus forming. So I have never seen the thrombus in the base or the mid-ventricular version. So only for the apical akinesis. Great question. And then Patty's asking, do antidepressants play a role perhaps in avoiding recurrence? Yeah, there's been a lot of interest in that. We certainly recommend that if you screen them positive for depression and anxiety, that they go and get treatment. We don't have enough data to know whether treatment for those disease processes actually helps with the risk of recurrence here, but we certainly want that to get treated. And there's also a high incidence in general after an MI heart failure. There's a high incidence of depression in those patients anyway. So I think very important to not miss that, but we don't know if that helps, with the recurrence of this disease. Yeah, great. Okay, great thoughts. And again, like I said, once you start looking for this, you see it absolutely everywhere. But I love treating it because it gets better, and that's very satisfying. So that's probably the most common alternative cause of heart failure that I wanted to discuss, but I want to throw in a few others in the rest of our time together. I'm putting up valvular disease here. We haven't really talked much about aortic stenosis, mitral stenosis, etc. But I just want to be very clear and that these diseases can cause heart failure. So I'm not talking about the disease causing a drop in EF, although that's possible too. Remember that heart failure is a clinical syndrome, okay? So it's shortness of breath, dyspnea on exertion, edema, congestion. That's what we call being in heart failure. And we talked about this at the beginning of this series. You can have cardiomyopathy or systolic dysfunction and not be in heart failure. Those are the people with EFs of 20% who are going to the gym every day. Hopefully you have patients like that. I certainly do. But being in heart failure means that you're manifesting with this clinical syndrome. So many things can put you into heart failure, okay? So severe left-sided valvular disease can cause your classic left-sided heart failure symptoms. And aortic stenosis is the best example of this. And you've probably all had patients like this that complain of shortness of breath or dyspnea on exertion, and you're thinking, oh, it's going to be heart failure, and you go and listen to them and you hear this raging aortic stenosis murmur, because that's the real diagnosis. So aortic stenosis can present for all the world looking exactly like heart failure. In fact, when we look at our 3 main symptoms of aortic stenosis, heart failure is one of those 3. So that would be the most common thing you're going to see as a valve causing what looks like heart failure. Mitral regurgitation can do this, but it has to be severe. So usually you're going to catch MR on an echo, or you might hear a murmur before you see or hear about heart failure symptoms. But it can, because again, you're just having backup of fluid into the pulmonary circulation, but instead of it being because of a muscle problem, it's because of a leaky valve. And then aortic insufficiency and mitral stenosis also both can cause heart failure symptoms, but these are going to be far more rare in practice. I put an asterisk by mitral stenosis because this disease, when it causes problems, it's in young pregnant women. So you have someone in her 30s who usually immigrated to the US from somewhere where they didn't routinely treat strep infections with antibiotics. She doesn't even know she has mitral stenosis. Right around end of 2nd trimester, she's getting shortness of breath that's out of proportion to pregnancy. I'm very sensitive to this right now because I'm well aware that you get shortness of breath in pregnancy. And then you listen and you hear a murmur, she gets an echo, and we're like, oh man, because this can be bad. The physiology of what happens in pregnancy, you increase your blood volume, you increase your heart rate. Both of those things do not go well with mitral stenosis. So this can be a very difficult problem to treat, but if you have a young pregnant woman and things are starting to come out of heart failure, swelling, etc., this is something that's on the top of my list to think about. Okay, so my point in just talking about all of this is not to discuss management of valvular disease, but rather that we don't want to mistake valvular disease for routine systolic heart failure, because our treatments are going to be pretty different depending upon what valve is involved. But I also want to make the point that it really should be severe, the severity of the valvular disease to cause symptoms. You can have a mixed picture. Moderate aortic stenosis plus an EF of 35%, that's probably enough to give you symptoms. But if you're just having just moderate mitral regurgitation, it's unlikely that that's going to cause heart failure. And then the last point is that all of these left-sided valve diseases I just mentioned, with the exception of mitral stenosis, all of them can cause systolic dysfunction. So once the valve disease gets bad enough, you start to have either a pressure or a volume load on the left ventricle, and the left ventricle starts to fail. When we find that, that's really bad, because now fixing the valve becomes much more difficult. But just keep in mind that that is kind of the final common pathway. So you might have a mixed picture going on, as mentioned. So we mentioned aortic stenosis already, and that heart failure is a classic symptom. Just as a quick reminder about it, you have that you can have a very harsh systolic murmur. If the S2 is quiet or absent, that's a marker of severity. So what I always teach the med students is, if you're in the ER and someone's coming in with heart failure or chest pain, before you give them nitroglycerin, you must listen to their chest. And if they have a systolic murmur and the S2 is quiet or absent, do not give that nitro. The reason is that aortic stenosis is preload dependent. You have a pinhole for an aortic valve. And if it needs a lot of pressure to get through that aortic valve. So if I give nitro, which basically dilates out the whole venous system, I drop the preload. Now I don't have enough pressure to push it through the aortic valve. I drop my cardiac output, syncope, death. And that's something we try to avoid. So that is my main point about aortic stenosis, is just they should not be on nitrates, either short acting or long acting. And you should not be aggressive with diuresis. This is a mechanical problem. There are no medicines that can fix it. They need replacement, and they need it now if they have symptoms. And you just try not to break them any further. And so just pretty much don't do anything if you diagnose it in the office. Just send them to cardiology, send them to a surgeon right away. Okay, so that's just points I wanted to make about aortic stenosis.
Dr. Toft, really quick on that point, do you have to have some caution with beta blockers as well in severe aortic stenosis for the same reason?
Yeah, you know, I've tended to have good luck with beta blockers, so I don't get as nervous about it. And usually these patients are already on blood pressure medications. And so if they're doing okay on their current regimen, then it's kind of, again, like if it's not broken, don't fix it. I just don't touch it too much. But I am cautious about what I add on, because you need a lot of pressure to get from the ventricle into the aorta. And in theory, if the aortic pressure is lower, I can get out better. But you have this really, really tight valve. And so my blood pressure medications aren't really affecting the valve area itself. So I just kind of cautiously back away and send them to the surgeon. But good question. Okay.
Rick,
and then,
yes. Rick,
please go ahead.
seems like you can't hear me. All right, go ahead, Dr. Toft.
Okay. All right, so just a few other disease entities to be aware of that you'll hear about and you may encounter in your common practice. So HOCM, or hypertrophic obstructive cardiomyopathy. This is a very severe example. This is my LV down here. These walls are enormously thick, enormously thick. It's not hard to imagine how this thick septum is impairing blood flow from getting out the aorta, because when you open this mitral valve, it's going to basically occlude against that septum. And there's a kind of vacuum effect that happens that even when the valve is closed, there's still enough of it and it's close enough to the septum that it can get sucked over. That's called SAM, systolic anterior motion of the mitral valve. So it's not hard to imagine how this impairs blood from getting out the aortic outflow tract. So let's talk just a little bit about HOCM. This is a familial, often familial autosomal dominant, but with variable expression. It's usually from a beta myosin mutation. The point of saying that is, if you know someone with HOCM or have a family or have a patient who's had it or any kind of intervention, their family members need to be screened with echoes for sure. And you can also sometimes find genetic counseling, but that's at more specialized centers. But at least they should get an echo. When young athletes die on the field, this is the #1 cause, an undiagnosed HOCM. So looks like I skipped some things. So they're usually not going to present with frank heart failure syndrome. They can, but more often it's dyspnea on exertion or syncope. There are the two things that people will have if they get symptoms from this. So we were talking about this in that picture, but you get this septal hypertrophy. So the septum is really big, and then the mitral valve and anterior leaflet gets sucked over, and then you basically can't get any blood out of the LV outflow tract. And so that can lead to syncope, no blood to the brain, or dyspnea when you get this transient backflow of blood from the left ventricle. So this is just for fun, what I showed to the med students. Normally, this is what your cardiac myocytes look like. This is called myofibril disarray. So there's just bad organization of the myocytes themselves is kind of the etiology of HOCM. So there are certain things, this is where clinical practice comes into play. There are certain things that make this worse. Okay, so you're trying to get the blood out of the LV outflow tract. And so anything that kind of impairs the amount of blood in the ventricle is going to make them potentially more symptomatic. So we want to avoid these things: dehydration, pretty robust exercise, vasodilation like alcohol. Okay, so in patients that you may have seen that they have an LV outflow tract gradient on their echo, or we say suspected hypertrophic cardiomyopathy, your initial, when you're seeing them before they go to a specialist, you want to make sure that they're avoiding these three things. Okay, that's going to be step number one. So they should stay hydrated, avoid diuretics, avoid caffeine or alcohol, and no competitive athletics. It's okay for them to, you don't want them to be bedbound, but these people should not be running marathons, and they should not be doing vigorous isometric weightlifting. Okay. They need to be referred to a specialty center. I personally also refer to University of Utah because there is highly coordinated care that they need. And especially if they have a gradient on their echo through the LV alpha tract or symptoms. I mentioned the family screening and counseling, which is something we can all do from our offices, at least recommend it. And then there are medications that we use here. So beta blockers and then verapamil and non-dihydropyridine calcium channel blocker are kind of your first mainstays of treatment. But then what they do in the specialized centers is if they still have symptoms despite being on these two things, they'll start disopyramide. So as a cardiologist, I will give them the first two, and then I send them to Utah where they'll put them on the third. But I don't routinely prescribe disopyramide myself because I find this to be a very highly subspecialized treatment. And then we do some stuff to see if they need a defibrillator because sudden cardiac death from arrhythmia is really the cause of them. And then we can actually do, we can reduce the size of the septum through two different procedures. Open myomectomy, where literally the surgeon cuts them open and slices off some of the septum. Or in what I think is barbaric but super cool, if they're not a candidate for the open surgery, we can take them to the cath lab. We find the branch that's feeding the septum. We squirt alcohol down it, legit alcohol. And what that does is it induces an MI. And that MI makes that septum not move anymore. And then you reduce the outflow tract gradient. So you give them chest pain. They come out of the cath lab having chest pain, but it's a purposeful, controlled MI. The first time I ever heard of that, I was like, I'm sorry, what? But pretty cool that we can do that or semi-invasively rather. So I have a patient right now who I saw in Carson City, and she definitely had symptoms. So I had her on the first two medications. She did not get much better. I had stopped her diuretics. I had her hydrate very well between echoes, couldn't get the gradient down. So I sent her to Utah. They put her on disopyramide, still having some symptoms. So she's getting septal myomectomy at the end of the summer. And they're fantastic up there at Utah and very communicative. Okay, so then just in the last few minutes that we have left, there are some other diseases you may come across where we have stuff getting deposited into the myocardium. And this is going to basically cause impaired relaxation or diastolic dysfunction normally. So anything that can infiltrate the myocardium can cause this. Sarcoidosis can infiltrate anywhere, that's granulomas. Hemochromatosis. So if you have any patients with a diagnosis of hemochromatosis, they all need an echo, but actually a cardiac MRI is better because we can actually see if there's infiltration. And then amyloidosis can also cause a cardiomyopathy. So we
Dr.
won't go
Toft,
through.
Patty's got a question for us.
Okay, sure.
Just a second here, Patty. I click unmute from my side, and then I think you get an alert asking to unmute yourself. There you go. Go ahead.
Okay, this is on the hypertrophic cardiomyopathy and, the family testing if it's discovered. And usually that's in the setting of, discovering it in young people, like sports physicals and stuff like that. I've got a patient who is she's in her 50s. Her sister, I think, was probably in her 60s. So, older. And died of a type of heart failure, and they called it leather heart. And she comes back to me saying somebody told her that we were supposed to test all the family members. And I wondered, is that true? Even if you're talking, these people might be in their 50s, 60s, or 70s once it's discovered. Or I never was of course, I didn't have access to records. I did refer this patient. I came up with a reason to refer her to a cardiologist, but that's what I was wondering.
Yeah, great question. Yes, no matter the age of discovery of diagnosis, all first-degree relatives should be screened because it is autosomal dominant, although not every case of HOCM is genetic. So if someone's diagnosed in their 60s, their siblings and their children all should be screened for it. The case of the patient you just mentioned, I'm not sure what they meant by leather heart. And, there's other things like dilated idiopathic cardiomyopathy that we think could be familial and we'd recommend screening for. So yeah, great question, but no matter the age of diagnosis, you want to send people at least for an echo. The genetic testing is harder to find. Like we don't do that, for example, in my current practice, but a center like Utah could do the genetic screening as well, because you can have people who have the gene but haven't yet manifested the thick septum. So great question.
Thank you.
Okay, so with that, we won't go into details about these other more rare kinds. They're just kind of fun. And I do want to tell you about this one just because you may not have heard of it before, but it is out there. ARVC or ARVD are the acronyms, arrhythmogenic right ventricular cardiomyopathy. So this is inherited. It causes right ventricular failure and rhythm disturbances. And the first manifestation can be sudden cardiac death in young people. This really needs an MRI because we see a thin RV wall and there's fat and fibrosis where there should be muscle. But this is autosomal dominant with variable penetrance. So if this is suspected or found, either living or dead, again, first degree relatives need to be screened. The best screening is cardiac MRI. There are genetic tests for this as well, though. And I tell this because of a very dramatic story in my own practice at a young woman in her 40s who came in post-arrest. And, we always search for a cause and hardly ever find a real cause of cardiac arrest if it wasn't an MI. But in her case, because we couldn't find a cause, we did an autopsy, and our autopsy was consistent with ARVC. So you can imagine that I had to then call her husband now weeks after she's passed and say, your children need to get screened for this. And of course, they've lost insurance now because she was the insurance holder, and he's worried about their whole lives of carrying a diagnosis. So this can be a very tricky thing to do, but just an important thing to be aware of is out there. So show you what it looks like on autopsy. Here's your muscular left ventricle. Here's your right ventricle. All of this is fatty infiltration. It should be muscle, but it's actually fatty infiltration. So there are some classic findings on EKG that we get excited about as cardiologists. You can always ask us if you have a funky EKG like this, you can refer them for abnormal EKG and we'll get excited about it. And then HFpEF we already discussed. So I'm gonna end there with 2 minutes to spare and see if there's any other questions or comments.
Excellent presentation, Dr. Toft. Thank you very much. Yeah, any other questions from the group, please feel free to unmute yourselves or write in through that chat box. Rick, do you have something?
You know what you call two orthopedic surgeons looking at an EKG?
Tell me.
A double-blind study.
I love abnormal EKG referrals. It's very satisfying to tell patients it's abnormal, but not really that abnormal. It's a good day at the office.
The things we get excited about in medicine.
Right? Each in our own field.
Yeah, I got to hop off. I just wanted to say thanks, Dr. Toft, and good luck with the rest of the pregnancy, and we really appreciate it. We'll see you next year.
Thanks, appreciate it. All right, well, thanks everybody. It's been great to have a nice little cadre of people, and I'll look forward to seeing you when I come back looking much less rested than this, and with the crying baby in the background. It'll be great.